Now, PAH is more common in women. It's often diagnosed between somewhere around 30 to 60, but it affects all ages and ethnicities, truth be told. But the earliest symptoms in patients with pulmonary arterial hypertension are often fatigue and breathlessness with exertion. Those symptoms are extraordinarily vague. They are seen in a whole host of other diseases. I can't tell you how many patients we see who have pulmonary arterial hypertension who have obesity as a comorbidity. And what they frequently tell me is that for years they've been told, well, this is just your obesity. You need to lose weight.
Hello, and welcome to part 1 of this deep dive series with me, your host, Dr. Saranya Ravindran. Let's dive in. So we're going to move to our deep dive questions now. So Dr. Chaisson, for those less familiar with PAH, tell us what exactly is it and how does it differ from other forms of pulmonary hypertension?
Excellent question to start off with. So there's multiple etiologies for why somebody can develop high blood pressure in the lungs or pulmonary hypertension. The most common by far etiology for pulmonary hypertension is due to elevated left atrial pressures from either diastolic or systolic congestive heart failure or aortic or mitral valve diseases. Those cause a static back pressure on the pulmonary venous and capillary circulation. Pulmonary arterial hypertension is a rare but very specific type of pulmonary hypertension where the problem is not in the pulmonary veins, but in the small pulmonary arterioles just before the capillary bed. Those arterioles become thickened, they become narrow, and the reason for that is that there is aberrant signaling going on between the pro-proliferative and the anti-proliferative properties within the vasculature. That aberrancy increases pulmonary vascular resistance. The downstream effect of that is increased pulmonary artery pressures, increased strain on the right heart, and eventually right heart failure and, if untreated, death.
And what are the primary causes or risk factors for PAH, and which patient populations are most commonly affected?
So pulmonary arterial hypertension can occur for a host of reasons, whether that is associated with conditions like connective tissue disease. Probably the most common connective tissue disease we see associated with this is scleroderma, but you can see this in mixed connective tissue disease or lupus. Patients with congenital heart disease like atrial septal defect or ventricular septal defect can also have pulmonary arterial hypertension, HIV, and certain drugs or toxins. There's also a significant cohort of patients who qualify hemodynamically and also histopathologically as having no clear reason or rationale for their pulmonary arterial hypertension, and we label those patients as idiopathic. And then there's a very small portion that have some type of genetic abnormality and a familial component. Now, PAH is more common in women. It's often diagnosed between somewhere around 30 to 60, but it affects all ages and ethnicities, truth be told. Interestingly, in 2025, what I would say is perhaps the largest growing cohort of patients to develop pulmonary arterial hypertension, at least anecdotally in my practice, is patients who've suffered from recreational methamphetamine abuse.
That's very interesting. I guess one thing that you've mentioned already to me is some of the symptoms involved and, how easily it could be mistaken for something else. And that would be my guess to this next question of mine. But I'm interested to hear from you. Why is pulmonary arterial hypertension misdiagnosed? What are the typical delays in diagnosis?
Great question. And, it's not because practitioners are not doing a good job. There are two factors why it's misdiagnosed and why there's delays. Number one, it's rare. So frankly, it should not be in the top 3 on most people's diagnosis unless you have some predilection to think so. For example, if you had congenital heart disease or scleroderma, it's going to be much higher on your differential diagnosis. But the earliest symptoms in patients with pulmonary arterial hypertension are often fatigue and breathlessness with exertion. Those symptoms are extraordinarily vague. They are seen in a whole host of other diseases. And frankly, most patients with breathlessness and fatigue have that because of a much more common condition. Remember, pulmonary hypertension and pulmonary arterial hypertension is a rare disease. And so, because of that, patients are often misdiagnosed with things like asthma or anxiety or deconditioning. What I would say is that for somebody who is breathless or fatigued and they're not getting better, or they are reporting progressive dyspnea despite the fact that they're not more overweight, they're not more deconditioned, their asthma treatment is controlled, you need to have a discerning eye and start to look outside the box at potential other reasons for this progressive symptom onset. That's sort of the approach that we try to teach our fellows and other physicians and providers in the field.
And how about in those patients who maybe have a background of some of those common conditions like asthma or COPD? I can imagine it can be quite challenging for you to then make a diagnosis.
For sure. I mean, you could imagine if somebody had underlying asthma as a child, or a patient who is obese. I can't tell you how many patients we see who have pulmonary arterial hypertension who have obesity as a comorbidity. And what they frequently tell me is that for years they've been told, well, this is just your obesity, you need to lose weight. But the problem with that is that most patients who are obese, and their weight is not changing, do not develop progressive symptoms. And so when your symptoms are progressive, but your weight is not changing or your activity level is not changing for clear reasons, that should be a clue that something else is going on besides just that comorbidity.
So you mentioned some of the pathophysiology that goes on when you explained what the condition is, but how does that then translate into clinical symptoms?
So remember I said a couple minutes ago that there's anti-proliferative and pro-proliferative pathways in a normal human body that govern endothelial function, smooth muscle function, proliferation of these components of your vascular bed. And they work sort of in tandem with each other to develop an equilibrium such that your vessels can react to different physiologic states. The problem is when these pathways and the signaling to those pathways becomes dysfunctional, then you can get vascular remodeling in the way that we think of in pulmonary hypertension, namely narrowing, which causes downstream vasoconstriction, endothelial encroachment on the lumen of the vessel, and then as the lumen gets small, you eventually can develop in situ microthrombi formation, which further impacts your pulmonary vascular resistance and cardiac output. Early in the disease, as this vascular remodeling occurs and your pulmonary vascular resistance increases, the RV can adapt to this by increasing sympathetic tone, by increasing its RV hypertrophy of the free wall. And those are really silent states. Most patients don't present very early in their disease. The symptoms and the functional impairment occur when the pulmonary vascular resistance gets to a point where the pressure needed to satisfy the afterload in the lungs that's created by aberrant pulmonary arteries cannot be accommodated by RV adaptation anymore. And when this occurs, the right ventricle's functional capacity becomes what we call uncoupled from the requirement of the remodeled PAs for blood flow. And it's at this point that symptoms like exertional dyspnea, fatigue, lower extremity edema, and then eventually the other signs of right heart failure start to creep up, and patients present to the physician or other provider.
And how far along, perhaps, in their disease journey might this occur?
Yeah, it's a great question. I mean, a lot of, historically, if you look back at patients who presented in the late 90s and early 2000s, most patients presented with florid right heart failure symptoms, much like you would see somebody come into your intensive care unit More and more as we have broadened the message about pulmonary hypertension evaluation and early diagnosis, we're seeing patients who have shortness of breath, maybe edema, maybe some signs of congestive heart failure, who've gone on to get an echocardiogram and they notice the RV doesn't look normal. And so those are patients who we can get them on therapy if the hemodynamics are consistent with group 1 pulmonary arterial hypertension and really restore a lot of their functional status back to a reasonable baseline.
So, how should clinicians use the World Symposium classification when approaching suspected PH or PAH?
Yeah, this, it's an interesting thing. So, why do we have classifications to begin with? And when you think about it, it's largely so that in research cohorts, we can put people into a certain bucket so that we're not just sort of treating people with different underlying causes or histologic profiles. So broadly speaking, these classes of or groups of pulmonary hypertension are organized based on this World Symposium classification. And there are 5 groups. The first group, as I've alluded to, is patients with group 1 PAH, that's precapillary pulmonary hypertension for the reasons that I previously mentioned. Group 2 is patients who have elevated pulmonary pressures or pulmonary hypertension, but it's due to left heart disease. Group 3 would be pulmonary hypertension related to lung disease or chronic hypoxia. The conditions of chronic hypoxia that we typically think of are either patients who are persistently living at high altitude or patients with obesity hypoventilation syndrome who have hypercarbia and result in hypoxia. Group 4 would be patients with pulmonary hypertension due to chronic thromboembolic disease. And then there's this special group, Group 5, which is sort of the catch-all bucket for other rare or miscellaneous causes like sarcoidosis or complex congenital heart disease, things like that, that aren't well studied in other groups. Using this, as I said, can be helpful for research, but clinically speaking, it's helpful for guiding diagnostic testing and then therapeutic decisions thereafter.
Thank you for listening to part 1 of our conversation. Make sure you tune in for the next installment in our deep dive series.